That's all good. Good afternoon, everyone. Good morning or good evening, wherever we're all calling in from. Thank you for joining us today for this very informative webinar on Orthelligent Vision. My name's Tom Fitzpatrick. I'm from OPC Health. I work in our athletics team here and also have been leading the Orthelligent Vision project here in Australia. Very fortunate to be joined by 𝗍𝗵𝗲𝗃 today, who's a sports podiatrist and has very fortunately and very nicely provided his time for us this evening to go through some case studies, his experience that he's had dealing with the software and the platform. Has been using it for about 4 months now, 3 or 4 months, and has some really good in-clinic evidence of how he's used it and how it's all worked for him. Prior to handing over to James, I'll just run through a few little slides to set up the webinar a bit. The first thing I want to talk about is the challenge in patient care. Patient diagnosis often depend on physical examination findings such as range of motion, joint stability, and gait parameters. Sometimes these can be inconsistent and quite subjective as well. They can also, these evaluations can also vary greatly between practitioners. This can be due to differences in experience and training. Also technique used during assessments, and also the interpretation of findings. So what I can see in a result may differ from what other people can see in results. Inconsistent and subjective assessments can ultimately reduce diagnostic accuracy and delay effective treatment and compromise patient outcomes. In many healthcare settings, patient care can be constrained by a shortage of time, staff, and resources. These limitations can have an impact on the quality, timeliness, and consistency of care delivery. This can lead to reduced capacity to monitor recovery trajectories or detect complications early in treatment plans, delayed adjustments to rehabilitation plans, and missed opportunities for early interventions that could prevent any complications from progressing and getting worse. And also, timely, accurate data is critical for effective patient care decision-making and management. However, much of the data used in current practice can be retrospective and take some time to retrieve. We don't have access to it straight away. Clinicians lack visibility into daily or weekly fluctuations in mobility, compliance, or pain levels. Treatment plans can be generalized rather than tailored, and this can lead to reactive rather than proactive care adjustments. So just stay on that slide there, James, one back. Yeah, beautiful. So there's a need for innovation. Us as humans, patients, clinicians always want to try the newest and greatest bit of technology, and patients have a hunger for that. As the treating patient population grows, especially with aging demographics and rising sports injuries, there can be clear and accelerating demand for modern data-driven rehab tools that are efficient, scalable, and personalized. Traditional outcome pathways can rely on subjective reporting, and providers and patients can lack quantifiable real-time feedback on progress, adherence to rehab programs, and outcome measures. Data-driven tools can track metrics like range of motion, gait patterns, strength, or balance, improving both motivation and clinical decision-making, and can also track progression in patients and allow them to see how good or how bad they're doing in their treatment pathways. Efficient rehab tools enable high quality in outpatient care, better outcomes through personalized recovery plans, cost reduction by minimizing complications, readmissions, and therapy delays, and a scalable rehab services that can reach rural or underserved populations. Just the next slide there. Thanks, James. So the importance of understanding the gait cycle. In movement efficiency, understanding the gait cycle helps improve walking and running efficiency, reducing energy expenditure. Injury prevention, so identifying biomechanical issues that lead to injuries, allowing for corrective measures. In a rehabilitation setting, monitoring the gait cycle aids in recovery from injuries or surgeries by tracking progress and adapting treatment when needed. Also got sports performance, so athletes can benefit from gait analysis to optimize performance, improve technique, and reduce the risk of injury. And importantly, as we're here today, a clinical diagnosis. Abnormalities in the gait cycle can indicate various health conditions, aiding in diagnosis, modality prescriptions, and treatment planning. Just the next slide there. Thanks, James. A little bit of a snapshot on what Orthelligent Vision is. I will leave a link and I will get in contact with everyone at the end just to send them some information, send them an online education platform that we have here at OPC Health called 𝗍𝗶𝗴𝗄, which will take everyone through what the actual system is, how it works. The focus on today's webinar is to see how it works in practice. We'll give a little bit of a rundown for those who aren't aware of it just yet. So Orthelligent Vision uses advanced computer vision and AI algorithms to track a patient's body movements without the need for any physical markers or wearable sensors. So it is a markerless motion tracking system. This eliminates the need for cumbersome preparation, such as attaching reflective markers or any type of special suits that may need to have those reflections on them that we can later pick up in a 3D camera. The system relies on a standard tablet camera to capture detailed biomechanical data, making it more accessible and less intrusive. It provides accurate tracking of joint angles, movement speed, and range of motion for clinical and rehabilitation applications. Provides real-time feedback. So one of the core features of Orthelligent Vision is its ability to analyze movement patterns and deliver almost immediate real-time feedback to both clinicians and patients. This response allows for on-the-spot correction of prescription or treatment pathways, enhancing the effectiveness of rehabilitation or performance assessments. Real-time cues or visual cues, metrics, or potential warnings can help to ensure that prescriptions are applied correctly, or if we need to change any prescription with the patient in clinic. This can also reduce the risk of injury and improve outcomes. Another great feature is the automated reporting. So after each analysis, the system will automatically generate a detailed report that include objective metrics such as joint angles, movement symmetry, stance, and support time. These reports are useful for tracking progression, documenting recovery stages, communicating results to patients, other healthcare providers, and insurance companies. Automation reduces the manual workload on clinicians and ensures consistency in data analysis is documented. Very easy setup and operation. So it's designed to fit seamlessly into clinical workflows. It offers intuitive operation with minimal setup. So what you can see on the screen there is all you need. All you need is a tablet, either an iPad or a Google tablet or a Android tablet. Either is fine. Doesn't need any calibration or technical expertise. It allows the clinicians to focus on patient care rather than setting up clinical device management and setting up clunky and sometimes messy gait analysis systems. The simplicity allows us to make the suitable for use of busy outpatient clinics in hospital settings, and can even be used for in-home patient monitoring via telehealth consultations for our regional clinics that we don't get to as often. And it's cloud storage, cloud data storage and sharing. All assessment data is stored securely encrypted in the cloud, facilitating easy access and sharing across different care teams. This enables multidisciplinary collaboration, remote consultations, and longitudinal tracking of patient outcomes. Clinicians can review previous sessions, they can compare progress over time, and share reports with other referring clinicians quite easily. This also supports a coordinated evidence-based care. That's a bit of a snapshot on Orthelligent Vision. I'll pass on to James so he can talk about his experience with the platform, his patients he's gone through. I'm sure I encourage questions along the way. If you want to put them in the chat box, please do. We can either answer on the spot, or if we answer them at the end there, we'll endeavour to do so. But James, thanks, and take it away.
Thanks, Tom. So as Tom mentioned, I'm a podiatrist based in Melbourne, and Orthelligent Vision is something that I luckily have been using for the past 4 months. So it's something that I'm still getting my head around, but it's a really easy platform. The app is really intuitive. It doesn't take much clinical time, which, you know, there's only so many things that you can do in a single consultation. So for every additional thing that you add on top of it, it adds clinical time. But this is something that does fit really nicely in terms of biomechanical assessment. And what I'll hope to show you is 3 clinical cases where I found it to be really, really useful. So, and then hopefully we got some time at the end to go through some questions. As I said, look, I'm not an expert at this stage. There is a lot of data that this AI can produce, and it is really helpful for basically, as Tom said, 1, educating patients, so that sort of patient buy-in, because it's all good for us to visually watch somebody walk in a corridor and to make a comment that, you know, your pelvis is doing this or your shoulders is doing that. But for the patient to actually be able to see the data, and then for you to make a modification and then retest that, and to show that the treatment that you're providing is effectively getting that patient closer to a more symmetrical gait, or you're working on whatever metrics that you're trying to treat as a clinician. So the first patient is a patient who is basically a semi-professional athlete, and he has this reoccurring proximal fibular pain that occurs when his training load starts to get above 70 kilometers per week. So his training style is a triathlon style training. And basically this has happened for years now, and it always decreases slowly when he brings his load down, but he often gets to a point where he has to completely deload. And this is problematic because it's often happening just before events. So as his load is starting to taper up, as he's building up towards events, he'll tend to run into this issue. And he's had a lot of different treatments. So he's had chiropractic treatment, he's had physio, he's had strengthening, he's had dry needling, he's had a whole bunch of things. So he came and saw me quite frustrated with the fact that every time he gets to about this 70 kilometer per week, this symptom would reoccur. And effectively the pain is sort of focal pain over the proximal fibular head, with some nerve symptoms that will tend to sort of radiate down that anterior lateral leg. Now on ultrasound, I've got ultrasound in the clinic, which is really helpful for these sort of cases. He showed the best, effectively some periosteal thickening with no fracture or bone callus formation of that sort of proximal fibular head. So compatible with a bone stress injury. The muscle and associated nerve are quite normal, but there is a point where effectively the nerve passes between that thickened periosteum and passes underneath peroneus longus, where there can be some irritation, and he did have a sort of positive to null, so that nerve was getting somewhat irritated. So from an assessment point of view, we're likely dealing with a bone stress injury at that peroneus longus insertion site, which is contributing to some local nerve irritation. So what we wanted to look at is how's his biomechanics, because the fact that he gets to this particular point each time and these symptoms reoccur tend to indicate there is something mechanical going on, or something mechanical at play. And the reality is just watching him in the corridor, I can't spot what's going on. There is too many data points for me to actually be able to really in detail look for small subtle changes in terms of his biomechanics. So this would have been one of my first cases using Orthelligent. So this is a bit of a spit out of the data that we got from the frontal. And the first thing you see here is this gait symmetry. So it's a symmetry of movement between his left and right, and this is quite low. So we should see gait symmetry well over 90%. For most patients, it should be like 98 to 100%. So if you're assessing most of your patients, you're going to see them nearly get 100%. So this is very low for someone who has such a high training load. The other thing you can see here is there is differences in terms of the stance time. There's also a difference in terms of his shoulder angle, and also differences in terms of his knee valgus and varus. So what the data is sort of showing you here is the left versus the right. So there are different metrics. It's looking at things like cadence. Now this can change depending on the speed that the patient's walking. This assessment is really easy to do just in the clinic. For some of the lateral stuff, I'll actually take the patients into a larger area or even just slightly outside the clinic because I don't have a heap of, our corridors are relatively narrow, so I don't have a great space there. But if you've got a treadmill, the lateral one can be done on a treadmill as well. The step time, we've got differences through there, so it's comparing effectively the left and the right, and it's good to have both the frontal and also the lateral there as well. So in his case, what I'm looking at is when I see a difference like the gait symmetry being quite often, I also see differences in the step time and the stance time. In his case, I'm thinking more along the lines of a leg length discrepancy. So I took him back into the treatment room and then measured both legs from the ASIS down to the medial malleolus. And lo and behold, there is an asymmetry there. And again, for someone, we know that for most people, they can compensate relatively well for a leg length discrepancy up to sort of 15 mil or so. But the problem is when someone has quite high load, subtle differences that are causing changes in the symmetry of movement are obviously going to put higher load in certain places. So what I did in his case was effectively just put a 4 mil heel lift into, so a real simple intervention, a 4 mil heel lift into his left shoe. And then we retested him straight in that same consultation. And you can see that the gait symmetry is now at 98. We also see a normalization where the step time and the stance time have become symmetrical now. So where we had differences in terms of that left to right and also the step time, we now have more symmetry there. The shoulder angle's unchanged, but that can also be sometimes as a result of slight scoliosis. We also see as well some change in terms of here as well, that left leg, the foot alignment's changed. So we've got improvements in terms of less external rotation. So if we go to the next slide, what we've basically, just by putting a simple heel lift in there, at the same time, this wasn't the only treatment that I did. I was using both a combination of radial and focus shockwave therapy to actually treat the symptomatic area, which was making a significant difference. But our main concern was the reoccurrence of this problem. And with his high degree of running, he was a patient who was not overly, he didn't like the idea of having an orthotic in his running shoes. And sometimes we see these patients. So he was someone who, from a starting point to look at orthomechanical intervention, we started off with a simple heel lift and discussed sort of progressing towards something like that down the track. So with the heel lift, we basically get a equalization of that step and stance time. So this is helpful because we get decrease in sort of cyclic bending movements through the fibula. We get normalization of that gait symmetry. So this particular person with a slight asymmetry, if they're working an office job and going for a 5K run a few times a week, this is likely not something for a healthy 30-year-old that is going to become symptomatic or problematic. But with that higher training load, those slight subtle asymmetries put load in other areas. And in this case, there was a particular, that particular spot seemed to be a reoccurring issue. We also see the foot progression. So this is that angle, effectively, it's looking at the angle, that angle of abduction of the feet. That shifted 6.5 degrees towards neutral. So decreasing some of that tibiofibular torsion. And we also see some reduced contralateral knee valgus, which again is probably just an indication of some of that rebalancing of his gait. So this was a really helpful case, and the combination of effectively treating him with radial focus shockwave and then also with this data from Orthelligent was really, for him, it was really useful data because this is a problem that had plagued him for a very long time, and he'd seen many, many clinicians, and everyone basically got to the same point with him where it's just, you just have to deload him. The symptoms would get better, but then once he would reload, it would get back in that same cycle. So this is where we were actually able to not deload him, because he said he had a specific event coming up and I was under strict advice when he first saw me in that first consult that I was not to, that he basically was here to have me help him get to his goal, but part of the treatment plan did not involve deloading. So that was off the table because this particular training event, this particular event that he was training for was significant to him, and we needed to do everything before doing that. So the combination of those things allowed me to effectively treat him. We got him pain-free and symptomatic whilst keeping his training load at the same amount. Now, the next patient, this is a really interesting, and this is, again, probably a complex one where there is just too much data coming in for you as a clinician to just objectively visualize. To do a gait assessment for a patient like this is really, really difficult. So this is a 58-year-old patient. He was struck by a car while cycling in December, and he had sort of multiple region trauma, injury to the foot, knee, hip. His current symptoms that he comes in with is inner groin pain, hip pain, balance loss, hypersensitivity to light, noise. He reports believing that he lost consciousness during the accident, and he'd had an inability to resume cycling and tennis, which is why he was coming in to see me. Now, I don't take on TAC cases, but he was an existing patient of mine, and he was paying effectively to see me with his own money and then trying to claim that through TAC. So for TAC and for those third parties, that objective data is really important. So being able to assess him and have effectively that objective gait assessment data was really helpful. So this is our frontal plane assessment. Now, the actual app has really nice graphics as well. There is a lot of data. So as a clinician, you can take as much or as little, and the app is quite intuitive. It's going to tell you effectively which areas are normal and which areas there is asymmetries or it's falling outside that normal range. So as a clinician, you can start to take that data and interpret that how you need to for the clinical presentation that you're seeing. So if we have a look here, our frontal plane assessment, we have our gait symmetry is way off. So we got a really low gait symmetry again, 83. So there's marked sort of disassociation of that left and right. The step lengths are also considerably different as well. So his left side, we're seeing significantly reduced shorter side on that symptomatic side. So we've got some protective strategies going on there in terms of avoidance of using, effectively he's injured his knee and his hip, so he doesn't have full range of motion through there. Again, we got excessive out-toeing. His cadence is also slow, consistent with that sort of bit of a cautious antalgic gait. Step widths as well, so we see a larger step width because he's more unstable, so he's likely suffered, and it was actually the data from this along with some pressure plate assessment where I was actually able to send back to his doctor and say, listen, I think he has had a head injury because he could not balance. He couldn't balance for the life of him, and his gait was very unstable. So that wasn't something that was necessarily picked up in. He didn't have a major head trauma, but he did seem to lose consciousness. So that's something that's currently he's seeing specialists for to look at some of the concussion-related changes. His gait variability is also irregular. So we see increasing gait variability. So it's become irregular with his stride time, consistent with some instability. And again, if we look here at some of the sagittal plane assessment, we see significant differences in sort of terminal hip flexion. So we got less hip flexion going through the left side, and that's compatible. His MRI showed that effectively pre-injury, he didn't have significant hip pain, but post-injury, he has a significant labral tear. He does also have some pre-existing degenerative changes that's been stirred up. So there's quite a bit of bone marrow edema that has basically the injury has set off in relationship to some of the pre-existing degenerative change. We also see differences in sort of his pre-swing ankle dorsiflexion. So both ankles are really failing to plantar flex at push off. So again, we're sort of looking at that's sort of indicating a weak propulsion. And this patient's lost a lot of basically steadiness on his feet. So there's a loss of power there. And at initial contact, we're seeing the knee effectively, we're seeing sort of a decrease in that impact absorption and asymmetry. So this is one of those ones where there's just heaps of data, and it's helpful to have a tool where for some patients I actually need to get the data and I can go through some of the key stuff that it spits out at the time, but sometimes I need to actually sit down and read the report and have a bit of time to think about how different elements of that report are relating to the patient's presenting complaint. So again, these are like some of the things that we're able to do with this. So when I'm writing a letter and a medical report, which ultimately is going to help him access the sort of rehab services and treatments that he's going to need post-injury, because this poor guy is riding his bike along and someone texting on a mobile phone has put him over the bonnet. So he's got, and he's an active guy who basically his outlet is sport. So being able to play tennis and go and cycle is his sort of mental outlet. So not being able to do those things is having a considerable toll on his life. So if we look at some of the kinetic chain type issues, we're seeing excessive out towing, increased dorsiflexion in that late stance. He's got a shorter lever arm to push off on, so he's got a weaker propulsion phase of gait. Bilaterally, there's a sort of a lack of that plantar flexion strength. So we're seeing decreases through there. So he's got decreased propulsion. He's got higher proximal demand. That's likely aggravating some of his hip and groin type pain. His knee alignment is relatively normal, but he's got a drop in his cadence. So he's got a more slow, steady gait that's antalgic, and he's got an increase width of support because he's less stable because of the concussion that he suffered as well. So again, this is likely also contributing to some of the patellofemoral and some of his medial knee pain. Hip and pelvis, we've got sort of a short step. We've got extra flexion through the thoracic spine, indicating again probably he's limiting that hip flexion. He was really, his main thing was a lot of iliopsoas and abductor tightness and pain. That was really contributing to his hip issues. We got some mild trunk lean as well, again suggesting that sort of poor lumbar pelvic stability. And again, that's going to cause additional stress through some of those lumbar facet joints. So we get some of these secondary drivers of pain as well. As the patient starts to compensate for dysfunction at the hip, they're obviously starting to load up different joints. The gait's becoming more asymmetrical, and that puts an increase. As that gait efficiency decreases, you're effectively putting more load through certain joints, certain muscles. So it's not uncommon for these patients to start to develop some other myofascial pain syndrome. So their symptoms can start to become a bit more diffuse. And again, we see these balance and vestibular type problems. So a wide step, we have a high gait variability. And again, this is probably consistent with some of the other clinical testings we did where I really pushed for the fact that he needs some sort of neuro assessment, and that's something that he's been able to get as a result of that report. So that case there is a really good one where being able to have that objective data, I haven't been able to reassess this patient at this time, but I'm seeing him in the coming weeks, and as such, we'll be able to reassess, and we can actually reassess and then make a comparison back to these existing findings. So having that baseline is really important, because one thing that insurance companies often want to know is how long is this going to take and how expensive is it going to be? So for me to be able to have some normative data and also to have a baseline in which we can compare his gait and say this particular person is not back at their full function. So as such, there is still a liability that is owed to him in order to get him back to as close to the state as he was pre-injury. This is another patient. This was really interesting. This patient's actually my receptionist, and she had a chronic history ever since she was a teenager of right side SI joint and lower back pain. It had been something that she is in her probably mid-40s now, but she has suffered and constantly seen myotherapists, chiropractors, osteos for pretty much since she was a teenager. And the reason she came to saw me is her myotherapist gave her some exercises to do, and it was a hip abduction exercise. And what she noticed is that when she was swinging her right side, it would basically drag along the ground before it come back to the central line, whereas on the left side it didn't. So she said to the myotherapist, I think there might be some sort of asymmetry. Are my hips out or something like that going on? Because when I do this exercise, my left one's fine, but my right one sort of drags before it gets back to the sort of center point. So my therapist suggested she come and see me for a gait assessment and to see if there was something going on there. So we can have a look here at her gait. So Orthelligent puts these markers, and you can even see here this drop. If you look at her gait, you can see the shoulder and the hips dropping to that left side. So basically that pre-scan, that first scan, which is based on that video there, her gait asymmetry is again quite low, so 87. We also see differences as well in that stance time. So the shorter leg, that left side, which is my suspicion that the left side is shorter, just from what she's describing, we have a shorter stance time and an asymmetry between the left and the right. We also see a shoulder drop on that left side. We've got increase in knee valgus as well on the left side. And then in her case, again, difficult from a body habitus point of view sometimes to accurately measure, but just in the clinical measurement, there was a leg length discrepancy there of, I think, close to 10 mil. And what I did in her case was start off using some different sized heel lifts. And what I ended up using was a 4 mil heel lift into her left shoe. And then I could reassess her straight away. And reassessing her, you see that the gait symmetry automatically, it's popped right back up. So it's increased by 11%. We also see a reduction in this bias towards the right side. So the gait symmetry in terms of the stance time has become more normalized. There's now only a 1% difference between the two. And if you have a look here, the shoulders now are symmetrical. So we have 0 degrees in terms of asymmetry. So we've got symmetrical movement between the left and the right shoulder. And the knee valgus has also improved as well through there. And you also see improvements with the asymmetry of the external rotation of the foot. So we see a reduction there by basically 2 degrees on both sides. So for some of these long standing, and you can imagine that when we have an asymmetry like this, where there's a leg length discrepancy, we have effectively some of these potential drivers. Pre that, we've got an increase due to that prolonged stance time. So you've got increased load through the right side. We've got an increase in that pelvic drop. You've got an increase in the trunk list to compensate for that. And you're obviously going to start seeing some change in terms of compression through discs and facet joints in the lower back and through the sacroiliac joint. So post-intervention, we see, again, a decrease in that stance time balance. So the balance between effectively the stance time left to right is now symmetrical. Our pelvis is more level, our trunk is more level, so we're sort of getting a normalization of those. And again, you're going to get more centralized loading through the spine. So for some of these, not every case we see in clinical practice is a nice classic biomechanical case, but patients that present with very long-standing clinical problems that effectively they've seen a lot of practitioners for and had a lot of treatment, but it just never seems to resolve the issue. They're the patients where finding these slight asymmetries, and from an intervention point of view, I don't really as a clinician mind how I get there, whether that's with an orthotic, whether that's with exercises, whether that's with just using a simple heel lift. But the ability to be able to see whether my intervention is making the patient more or less symmetrical is really, really helpful. And for patients to have that data, it really does give them trust in the process as well. So that is the last of my cases, and we've sort of finished up with enough time that we hopefully be able to answer some questions.
Thanks, James. Really, really good and insightful. That's just a bit of a snapshot on how you can adapt and adopt these technologies into your practice, and something that doesn't take a lot of time, and you get a lot of data and information out of them and help you treat your patients. Is there anyone who's got any questions based around James's use of the software, and anything along the lines of that, or anything about Orthelligent itself? Like I said, I'm going to send out some really good informative education resources for you to really get the ins and outs of how the software works and how you can use it in your clinic. I will send that at the end, but if anyone's got any questions or feedback or thoughts on the presentation, please type it in the chat box, or get yourself off mute if you want to ask the question itself.
Did you have any questions that come to mind, Tom?
I've got one question. Prior to having access to Orthelligent coming out, because it's relatively new, what was your use of gait analysis in your clinic? Was there any limitations? Did you do it? Was it not performed much because you didn't have much access to any sort of software, or what was the cases that you did in that perspective?
So basically, in clinic, when I first graduated, we used to use, I think it was called Silicon Eye or Coach's Eye, which was effectively had like a treadmill with a little camera set up on it, but it actually required you to manually put in the data in terms of you had to make lines and bisections and stuff like that. And again, it's just not very objective. The way I might place a line is different to another patient, or whereabouts in the gait cycle you place that line is different between different practitioners. So that was one version, and then it sort of moved to using an iPad where you just take a video and you'd use an app like there's various apps on there which effectively allow you to slow them down, but basically it's the same sort of thing. It's got some real basic functions where you can place a line or a bisection, but it's not very sophisticated. And there's a lot of subjectivity in where you place those lines. And then for the past maybe 10 years, I've used pressure plate mapping as well, which is also a really useful tool. And those two tools actually work really well together because they give you different data sets. What Ortelligent's able to do is give you effectively sort of kinematic data of what's happening proximally, whereas a pressure plate mapping gives you data of where load is basically going through the foot in terms of mapping that. So there are ways that you could sort of make inferences in terms of what may be happening proximally, but with pressure mapping, you just don't have that ability to know what the knee's doing at that particular time. So being able to use those two in combination is really helpful. So that's primarily the way I've tended to use gait assessment. So this has been, as I said, really useful for patients that present with sort of proximal type asymmetries. And you can see there's a lot of data that we can look at from a gait point of view, and just visually watching someone and taking a little bit of data on a little bit of video on an iPad or something, it's often not very objective, and it's not often that helpful in order to make these basically sort of clinical determinations. And then the reality is that the next step up from there is a proper kinematic gait lab, where the time and the cost of something like that is very expensive, and potentially if you're being used for research, or you're an elite athlete trying to get the next 1%, that might be something that you pay a biomechanist to look at and to do a sophisticated analysis. But this is something in your clinic that you're basically able to create a 3D gait lab effectively off your iPad and get really useful data within 10 10 to 15 seconds in most cases.
Yeah, great one. I do have another question for you, but I'll run through a few of these other ones just quickly. Vanessa, is it user-friendly with treadmill? It is. There is still work in progress in the back end through our technicians in the back end who are just fine-tuning that a bit, but it does work on a treadmill. It will be consistent with your results. Running, not so much just yet. It can walk up to about 6 or 7K an hour. It's between 6 and 7K an hour. So it's quite a fast-paced walk. Running is not currently available on the platform, but potentially down the track it may look to doing that as well. Stuart, minimum distance required for an analysis. So we base it off the amount of steps that you can get into the analysis. So the idea is the patient can walk back and forward as many times as they need on a lateral, and then forward and turn around and go backwards the other way from a coronal or frontal plane. From a sagittal point of view, we want to get 6 steps in, so enough to get 6 steps in. You've got 30 seconds to film it, so if you've got a patient who's not particularly quick, as long as there is 6 good steps where the patient is in full view of the camera at all times, that will be enough data there, enough steps for them to get data. It does base itself off averages of all the steps, so the more steps you get, the greater collection of data that they can then use to give you the results. But yeah, so 6 steps on the sagittal view, and then 5 steps on the coronal view there. We'll give you that point there. Wayne,
there's a nice guide on there as well. So when you're setting up to take your video, there's actually on the screen like a picture of a person, and it almost goes sort of green when they're in the right sort of zone. So it gives you an idea of how far away the person should be. So it's really easy. You don't have to measure anything out. As you pull your tablet out and you switch the camera on, it's basically going to tell you how to set up for it, and basically the person needs to be about this size on the screen, and then you just have them walk towards you, walk back, and